In this video, we show how a scaphoid fracture can be treated from palmar percutaneously with a shark screw allograft. The hand specialist Dr. Simon Saylor is operating. The surgical setup is essential for the success of the operation. Particularly, the position of the intraoperative X-ray device is important, as well as the use of a large roll on which the hand to be operated should be placed on. All surgical steps are performed under intraoperative X-ray control. It is advisable not to change the position of the device for the entire duration of the operation. Using a K-wire, we mark the longitudinal axis of the scaphoid with a pen under X-ray control. The 0.5 centimeter skin incision is made slightly distal to the distal pole of the scaphoid, over the scaphotrapezial joint at the radial border of the tendon of the flexor carpi radialis muscle, distal to the rascette. After skin incision, probe and spread with scissors and palpate the distal scaphoid pole. Then, the distal scaphoid pole is probed without a machine using the K-wire under X-ray control. The entry point of the K-wire at the distal scaphoid pole should be as dorsal as possible. Once it is found, the K-wire is inserted with the machine. Important, we place the K-wire at an angle of about 30 degrees to the dorsal. The K-wire runs palmar radially over the scaphoid tuberosity towards the proximal scaphoid pole. The intraoperative X-ray control should include at least 3 levels of projection: dorsopalmar, lateral, and stab, as well as X-ray with the rotation of the forearm. As in this case, the wire lies very nicely in the lateral plane, but not perfectly in the dorsopalmar plane. We place another wire directly radially next to the already inserted wire and try to optimize the position of the new wire under X-ray control so that it will later fit perfectly for the insertion of the shark screw. After removing the first K-wire, the X-ray is checked again in 3 levels. If the wire does not fit centrally, the wire has to be repositioned again. We measure on the wire how deep the shark screw has to be introduced. Usually the adequate length of the bone bridge is about 26 millimeters. Before we start drilling, a final intraoperative X-ray control is necessary in all levels. Now we drill the core hole for the shark screw cut over the wire. In this case, we choose a blue-marked 35 millimeter shark screw cut. The exact drilling depth can be read from the laser marking. It is important not to drill through the proximal pole of the scaphoid. An intraoperative lateral X-ray with a drill in the scaphoid is useful for checking. The thread is first cut with the machine. In order not to perforate the proximal pole, the last threads are cut by hand. Then we slowly rinse the canal with physiological saline solution while protecting the tissue, so that the fine bone chips do not block when the shark screw cut is screwed in. Now the shark screw cut is introduced in without much resistance with the hexagonal screwdriver, also under X-ray control, until the screw is in contact with the proximal fragment. In order to cut off the protrusion of the screw, we take a thin, narrow saw blade and push it parallel to the screw up to the scaphoid, and saw the screw 90 degrees to the scaphoid. Over the now created predetermined breaking point, we break off the protrusion with the lyre towards the palmar. If possible, the patients are treated without fixation. Depending on the stability of the injury, a plaster cast immobilization is sometimes applied for 2 weeks. In the case of pseudoarthrosis, up to 6 weeks.